Hello guys, welcome to another episode of Do I Suffer session. In today's video, we will discuss everything you need to know about pancreatic cancer. After watching this video, you will know the types of pancreatic cancer, its classification, the subtypes, the epidemiology, the risk factors, the clinical features, the findings of clinical examination, the results of laboratory and imaging techniques, and lastly the treatment. Okay people, now that we discussed what this video is all gonna be about, let's smash it. To begin with, pancreatic cancer is classified as pancreatic exocrine tumors and pancreatic neuroendocrine tumors. Today we will go through the pancreatic exocrine tumor and briefly review the neuroendocrine part. The most common pancreatic cancer is the ductal adenocarcinoma, with occurrence of 90%. Less common types of pancreatic cancer are pancreatoblastoma and pancreatic giant cell carcinoma. To begin with, pancreatic cancer is the fourth most common cancer death worldwide after lung cancer, large intestine cancer, and breast or prostate cancer in females or males respectively. The incidence is 13 people per 100,000 for men and 10 people per 100,000 for women. The mortality rate accounts for 6% of cancer deaths. The age of onset is 60 to 65 years of age, and at the time of diagnosis, the disease is usually on advanced stage. The metastasis of pancreatic cancer is on regional lymph nodes, liver, large intestine, and peritoneal infiltration. The prognosis is really poor, with only 5% having 5-year survival rate. Before moving on to the major risk factors contributing to the pancreatic cancer, we need to mention that 70% of the pancreatic cancer are found on the head of the pancreas, 20% are found on the body, and 10% are found on the tail. This is important for the symptoms as well as the treatment of each case. Speaking about the risk factors causing the pancreatic cancer, the smoking, as in most cancers, is a major risk. Heavy alcohol consumption, diet rich in meat and smoked food, and poor diet in fibers. Diabetes mellitus is associated with increased risk of developing pancreatic cancer and is highly suspicious, especially when it's newly diagnosed in elder people or there is a sudden increase in the needs of insulin to a pre-existing disease. Chronic pancreatitis is a major risk factor. Worth to say, it increases the chance of developing pancreatic cancer by 20 times. Oncogene mutations such as KRAS and hyperexpression of the human epidermal growth factor receptor HER2, which is analog to epidermal growth factor. Mutation or deletion of tumor suppressor genes like P53, P16, BRCA2, and DPC4. Changes are also noted on the expression of the growth factors along with their receptors. For example, epidermal growth factor, vascular endothelium growth factor, fibroblast growth factor, insulin-like growth factor, and lastly, hepatocyte growth factor. 10% of the pancreatic cancers are associated with inherited genetic syndrome like familial atypical multiple mole melanoma, hereditary pancreatitis we mentioned in one of our last videos that is associated with PRSS1 gene mutation. You can click on the right of your screen to see the full video and learn more about chronic pancreatitis. Moving on, Lynch syndrome, which is the hereditary non-polyposis colorectal cancer, von Hippel-Lindau syndrome, Hughes-Jeter syndrome, and lastly, ataxia telangiectasia. On this part of the video, we'll go through the clinical features of the cancer according to its localization. As we said earlier, 70% of the cases are located in the head of pancreas. It's going to be presented with significant weight loss, painless obstructive jaundice, and belt-shaped epigastric pain. Diabetes mellitus can occur 2 years earlier than the mentioned symptoms. Other symptoms include weakness, itching, nausea and vomiting, and weight loss. When the pancreatic cancer is located in the body or tail, due to its location, rarely is presented with jaundice, excessive weight loss, and constant pain on the back which is not changed with position. This is associated with infiltration of retroperitoneal nerves, migratory thrombophlebitis of the upper extremities are known as Troser syndrome due to paraneoplastic symptoms. Going through the clinical examination, on early stages the clinical examination will be physiological. Yellow discoloration of the cornea, clay color stools, and dark urine are the symptoms most commonly will drive the patient to the doctor. The so-called Corvair sign is the enlarged, non-tender and painless gallbladder. Hepatomegaly can be presented in 50% of the cases, however, is not associated with hepatic infiltration of the cancer. On advanced stages, palpable mass will be noted on the epigastrium, which usually means that the cancer is on the body and tail and is not resectable. Palpable enlarged supraclavicular lymph node called Vichor's node, infiltration and thrombosis of portal vein presented with ascites and symptoms of portal hypertension, enlarged periumbilical lymph node called Sister Mary Joseph's nodule, or metastasis to the pelvic peritoneum and Douglas base, which on digital rectal exam are palpable and painful. This is called the Lambert's shelf. On laboratory exams, we will have increase of direct bilirubin, usually between 18 and 30 milligrams per deciliter, and increase of the cholestatic liver enzyme alkaline phosphatase, ALP. The tumor markers, such as the cardiac antigen 19.9, on early stages it's gonna be normal, but on advanced stages it can increase above 1000 IU per milliliters. However, when the tumor is resected, the levels of this tumor marker CA19-9 will fall back to normal. If it rise again, it means that this is a sign of recurrence. Thus, this marker is used for post-surgical surveillance. Other tumor marker is the CA cardiac embryogenic antigen. From imaging techniques, we can use the ultrasound. It will relieve dilation on intra and extrahepatic bile ducts, and if the patient is not fat, it will relieve the composition of the tumor too, whether it's solid or cystic. Triphasic CT scan of abdomen with arterial, portal venous, and delayed venous phases. This will show the association of the pancreatic cancer with these structures. Now, if we find a dilation of intra or extrahepatic bile duct and the pancreatic duct in the absence of any mass on imaging, is a sign of pancreatic cancer. Other techniques used in the diagnosis are the MRCP, MRA, magnetic resonance angiography, ERCP for biopsies or therapeutically for stent placement, endoscopic ultrasound. Lastly, it's important to note that 1 out of 5 people undergoing laparotomy for the excision of the tumor is found out that is non-resectable. Thus, it is advised to perform diagnostic laparoscopy before moving on to the surgery. Moving on to a very important thing about all cancer, which is the biopsy. Biopsy now is important for the following reason. Firstly, because not having a biopsy can lead to unnecessary pancreatectomy. It's essential for the type of the chemotherapy that is going to be used, and we have to highlight that positive biopsy is conclusive. However, negative biopsy does not exclude pancreatic cancer. Okay people, approaching the end of this video, we need to mention that the staging is according to the TNM. Now, the therapy of pancreatic cancer can be surgical therapy, which is advised in only 20% of the pancreatic cancers found on the head. Even smaller percentage is used for the cancer of the body and tail. The surgery for the head of the pancreas is the Whipple procedure. As you can see on this picture, The Whipple procedure is the resection of the head of the pancreas, then distal stomach, then duodenum, then gallbladder, and the common bile duct. For the cancers of the body and the tail, left pancreatectomy from the level left from the superior mesenteric vein accompanied with splenectomy. The continuation of the gastrointestinal tract after the resection of the above-mentioned organs is achieved by pancreatonjejunostomy, hepatojejunostomy, and gastrojejunostomy. Sometimes Whipple procedure can be done with preserving the pylorus of the stomach. Regarding the chemotherapy and radiotherapy can be done neoadjuvantly to decrease the size of the tumor and increase the mass that can be resected. If the tumor is non-resectable, it can be used for palliative measures. Post-surgical complications can be delayed gastric emptying, especially when the procedure done is Whipple, and it requires nasogastric tube for more than 10 days. Bleeding can be found during the surgery or post-surgically. During the surgery is due to the damage of the portal vein or the superior mesenteric vein. Post-surgically, which is due to incomplete ligation of the vessels or autodigestion of the vessels. This will require revision surgery. Another complication can be a partial rupture of the pancreatic on jejunostomy anastomosis and the escaping of the content. In peripheral pancreatectomy, you can find the left infradiaphragmatic abscess. As I promised in the beginning of this video, we're gonna briefly go through the pancreatic neuroendocrine tumors. The first one, insulinoma, is the most common type of pancreatic neuroendocrine tumor. It's associated with the beta cells of the pancreas, and most of the symptoms are due to hypoglycemia. The classic diagnostic triad is the Whipple's triad, which consists of the hypoglycemia symptoms, low glucose level less than 50 milligrams per deciliter, and relieving of symptoms after IV glucose. Others is gastrinoma, which is also called Zollinger-Ellison syndrome, which is increased production of the gastrin leading to ulcers, glucagonoma, which is associated with the alpha cells leading to overproduction of glucagon. It presents with dermatitis, deep vein thrombosis, depression, diabetes, decreasing weight, and diarrhea. VIPoma, vasoactive intestinal peptide, lead to WDHA syndrome, which consists of water and diarrhea, hypokalemia, and lastly, achlorhydria. The last one is somatostatinoma, is a tumor of pancreatic delta cells leading to overproduction of somatostatin. These will lead to glucose intolerance, steatorrhea, gallstones, and achlorhydria. After going through everything you need to know about pancreatic cancer, here is a high-yield exam question. Which of the following is not part of the Whipple's procedure? Excision of the distal stomach, excision of the head of the pancreas, excision of the gallbladder, or excision of the jejunum. You can put your answers below in the comments. For those of you guys which sticked until this part of the video, please hit that like and subscribe button and let me know in the comment section below if you have any questions. I will also drop the links of our social media in the description of this video.